an inch long.
So it's very small.
Very small. Many of these seeds are placed. This technology was first developed in the 70s, and it was done by hand, open. One would do an open incision and put these seeds in the prostate. Unfortunately, not everybody had a good distribution because you need a very even distribution of the radioactivity in the prostate. The advantage is that what's being radiated are electrons are coming from the radiation source, and they travel a very short distance, so that the tissue around the prostate, that is, the nerves that control erection, the sphincter muscles, the rectum and the bladder, are not damaged.
Now, when you place the seeds, when somebody places the seeds, who does the placement? You or?
It's a combined procedure between the urologist and a specialized radiation oncologist. So we're both in the operating room, both working concurrently, plus a very specialized technician who runs all the computer software that is necessary during the case.
Now, how do they enter? Through the urethra?
No. The entry for the seeds are, one puts a ultrasound in the rectum so you can monitor the prostate, and the seeds go in with hollow needles. This way, there's a space between the scrotum and the rectum that the prostate is only 1.5 centimeters distant, and so the seeds are placed through that.
Directly?
Without an incision. Mm-hmm. Patients go home the same day.
And this is either local anesthesia?
Usually it's a general anesthetic. General anesthetic because...
Painful?
Not painful. The patient has to stay very, very still because a grid is determined, and the computer tells you where to put the seeds, and so things have to be very fixed for about 20 minutes.
Now, these seeds have a certain half-life because these seeds are permanent.
That's correct.
Now, what is the half-life?
Half-life of the cesium that we're now using is 7.5 days. And this means that the symptoms of urinary frequency and urgency, which are part and parcel of the procedure, last for a very short time. And most men are really back to normal within a month.
Then the other procedure is the prostatectomy.
Yes.
And you mentioned one other.
And external radiation. External radiation was actually developed here locally up at Stanford 30 years ago for patients who were too ill to undergo surgery. External radiation for prostate cancer is really not used as a primary method anymore. If we feel that there may be a spread of the cancer into the pelvis and lymph nodes, then external radiation will be given to the pelvis as a secondary treatment. The other method of treatment, of course, is surgery. And surgery is to remove the prostate and the seminal vesicles. And it can be done in a number of ways.
Now, you had shown us on the model before, where would you have choice of incisions.
Exactly. An incision could be here above the pubic bone, entering, pushing the bladder forward, and removing the prostate and the seminal vesicles, and then moving the bladder forward and sewing the bladder to the end of the urethra. This is basically the same, done in any way, no matter which way we enter. We can enter suprapubically, we can enter perineally, and then it can be done laparoscopically, where you put a camera in and several holes to allow your instruments to go towards the prostate. And it can even be done using a robotic machine, which facilitates the laparoscopic procedure.
Now, what happens with the procedure is called nerve-sparing prostatectomy?
Right. One of the really terrible things that's happened in the past is a man would come to the office, and this happened to me a number of times, with no symptoms. We find, because of the PSA or the digital rectal examination, we find a prostate cancer. We propose surgery. The fellow 6 months later comes back and says, "Doc, thanks an awful lot. I didn't feel anything wrong with me. Now we've had my prostate out. I'm incontinent, and I can't get an erection." You should have left me alone. No.
So
then we developed methods of solving these problems. And the nerve-sparing procedure is one of the methods. When there's cancer only on one side, say only this lobe of the prostate had prostate cancer, on this side we take a generous margin and take the nerves. On the other side, we push the nerves away and leave them alone. And this increases the probability that the patient will maintain normal sexual function afterwards.
So incontinence occurs in a certain percentage, like less than 8%?
That's correct. That's correct.
So most people do not have incontinence?
That is correct.
And what is the percentage with the sexual dysfunction problems?
Well, that's age dependent, but it's quite high. It's quite high. Notwithstanding that, we have many medicines today and procedures that can restore erections. Because what is lost after the loss of erections after surgery or treatment of prostate cancer is not the ability to have orgasms. The ability to have sexual pleasure remains. Sensation remains. What is lost is the ability to have an erection. And we have now a number of medicines and procedures that can solve that today.
So Viagra is one.
Viagra is one. Cialis is another.
And that
Levitra.
helps men after prostate?
Very much so. In fact, today, after prostate surgery of any kind for cancer, we start the person on, if they're interested in being sexually active, we start them on medicines like Viagra within a month and keep them on that medicine for an extended time until things return.
In the remaining 2 minutes to our show,
yes.
What about the hormone therapy? There's some mention of that.
Certainly. When prostate cancer is outside of the prostate and cannot be cured surgically or with radiation, then we know that we can slow the growth of prostate cancer by blocking male hormones. And in the past, we used to give men female hormones in order to block the production of male hormones. That had a high incidence of strokes. So fortunately, over the past 10 years, LHRH agonist, which is a chemical which tells the testicles not to produce testosterone, is used. And this indeed lowers the PSA and stops for an extended period of time the growth of prostatic cancer cells.
Now, some centers use these things like Lupron, make the prostate smaller and then do the surgery. Do they do that still?
Sometimes, yes. For when we do brachytherapy, if the prostate is very large or if the patient is having a difficulty urinating, we will use these medicines for 3 months and the prostate size will reduce by about a half. We do not do that when we are planning open or laparoscopic surgery because surgery has been found to be more difficult after the use of Lupron.
Now, for the take-home lesson for everyone in the home audience is to get a PSA starting
age 40, every year, keep it in your records, very important. Starting at age 50, digital rectal examination. If you have a family member who has had prostate cancer, then you should start both the digital rectal exam and the PSA at age 40.
And keep careful records not only with your urologist or a family practitioner, but keep a record at home.
Exactly, because we're looking at keeping records for 20 or 30 years, from 40 maybe to 70. And physicians may not be able to keep records accurately that long, but these are your records and you should write them down somewhere. It's just a number.
And to see your urologist if there's any symptoms, painful urination or blood in the urine.
That's true.
Or
That's true.
Pain with intercourse.
Exactly.
So thank you so much for joining us at Health Talk. And this was a short, brief episode on prostate cancer. It's a very big topic affecting half our population, the men. And thank you very much for joining us. I hope if our home audience enjoys this to contact Dr. Monzone, contact us. And thank you for joining us. And we will hope that Dr. Monzone will join us again on a similar topic.
Thank you.